Have Dr. Perminder Sachdev's recorded presentation on cognitive function. Unfortunately, Dr. Sachdev was unable to make it to ARDD this year as he is currently in India on another speaking engagement, but he has provided his presentation in video format. Dr. Sachdev's major areas of research are drug-induced movement disorders, brain imaging, cognitive aging and dementia, and his work has been published in over 900 peer-reviewed journal papers and 6 books. So please divert your attention now to the screen to watch the presentation.
Hello, my name is Perminder Sachdev, and I work at the Center for Healthy Brain Aging at the University of New South Wales in Sydney, Australia. My task today is to speak to you on the assessment of cognition for the XPRIZE. The main points I wish to cover are why should we assess cognition and which aspects of cognition, the challenges in measuring cognition, what are the suggested measures, how do we address the confounds, and what secondary markers of brain aging should we include. Now, the first argument about why cognition. Now, of course, our interest is in brain aging. And as you all know, there are some changes that happen with normal aging of the brain. In addition to that, the brain also accumulates pathology as it ages. We therefore could have aging-related changes or speak of age-related changes, which include both normative aging as well as pathology. But functionally, what is most relevant is the age-related change in cognition. Of course, the changes in brain structure and morphology are also important, but it is much easier and more relevant to measure cognition. And here again, we have to distinguish between normal cognitive aging and cognitive aging that is associated with disease. And people have tried to assess normal cognitive aging using cross-sectional data as well as longitudinal data. And each of these strategies has its potential drawbacks. Cross-sectional data, of course, you take a sample of people over the age span and assess them cross-sectionally, and from that deduce what changes might occur as one ages. Of course, we know that this is confounded by what are called cohort effects, because we know that with each generation, there is a change in the performance on IQ tests. You may be all familiar with what is known as the Flynn effect, which suggests that with each generation, the IQ as measured by IQ tests increases by about 5 to 6 points. And this will confound our assessment of age-related change if you use a cross-sectional approach. But of course, if you use a longitudinal approach, the first drawback is that you would need a study which spans several decades. And of course, there is not only attrition of participants in such a study, but also attrition of researchers. And such studies are extremely difficult to find. If you use shorter studies, the other confound is that of practice effects, because the same individual is taking the same tests repeatedly over a period of time and becomes better at performing that test. And therefore, at least for short-term studies, you often see an improvement rather than worsening on most tests. So one can probably talk about a primary aging process, which is so-called normative aging, and certain changes that occur in cognition in relation to normative aging. We are referring to these as fluid abilities, and we'll come to that in a moment. And then, of course, the changes that occur in relation to pathological aging, which has been referred to secondary aging in this model. And these changes affect both the fluid abilities as well as the crystallized abilities. Then, of course, in the very end of life, very close to death, there is a terminal drop or decline across the board. And this has sometimes been referred to as tertiary aging. This should not interest us very much today. Now, with crystallized intelligence, we refer to skills, abilities, and knowledge that is overlearned, well-practiced, and familiar. Examples are vocabulary and general knowledge. And crystallized abilities remain stable or gradually improve at the rate of about 0.02 to 0.003 standard deviations per year through the 6th and 7th decade of life, after which they plateau and may decline to a small degree. However, fluid abilities refer to abilities that involve problem solving and reasoning. These include innate ability to process and learn new information, solve problems, and attend to and manipulate one's environment. Examples are executive function, processing speed, memory, and psychomotor ability. And these abilities reach their peak in the 3rd decade of life and then gradually decline, with this decline worsening or exacerbating after the age of 65 or 70 years. And this has been looked at in various studies. For example, this example is from Salthouse, who used both the cross-sectional as well as longitudinal approaches to look at these age-related curves for memory, speed of information processing, reasoning, which is an executive ability, and language. And you can see there is a decline in these abilities, which exacerbate over the age of 65 or 70 years. Now, which aspects of cognition are we therefore interested in? We are interested in the fluid abilities, and these are executive function, processing speed, working memory, psychomotor speed, and episodic memory. And one could possibly look at a global composite from these various domains of functioning. Now, in order to determine if candidate therapeutic intervention is successful, the improvement must be at least offsetting 10 to 20 years of decline. For example, as if they were, these individuals were 10 to 20 years younger, functionally speaking. And these improvement could be in the cognitive domain globally or in individual domains. And then, of course, they should be across the board in muscle, cognition, and immunity. And a before-after design is what is required to look at this at an individual level during the treatment period. Now, there are various challenges in measuring cognition. There are demographic challenges, of course. Age, as we have seen, is important because if you're measuring individuals between the ages of, say, 40 and 60, the change is going to be very different from individuals between the ages of 70 and 80. Sex, education, ethnic background, language are all important. And in fact, many tests are available only in a few languages. And of course, the cultural fairness of the tests that you use can sometimes be questioned. Practice effects, we've already spoken about. Whether normative data are available and what is the quality of these normative data, especially for the ethnic group that is being studied. How trained are the staff? What are the other confounds, such as depression, poor effort on the part of the examinee, and the confounding by intervention, so that the intervention is not actually making the person practice on the very test or very function that they're being tested on. And then, of course, there are different factors that could be influencing cognition through the lifespan. And these are all important because you have to account for these both in terms of the choice of test as well as your choice of the control group. It is very important to therefore have a balanced control group, which is matched for age, sex, and the various factors that could be confounding factors in the assessment. And then, of course, your choice of test. And the suggestion that we have made is that it may be best to use computerized tests. The administration of these tests is more standardized. And many of these tests are available in multiple languages. The two batteries that are suggested here are the NIH toolbox, and the CAN tab. But of course, these are just suggestions. One could possibly be looking at other tests that have been validated in certain populations, and there could be possibilities of using non-computerized tests as well, if those are the ones that are most suitable for a particular question being investigated. One would also measure vision and hearing, look at the sensory status of the individual, and certain questionnaires could be used for confounds, for example, mood in particular, especially depression is one thing that neuropsychologists often take into consideration when examining function. So NIH Toolbox, for example, has these tests in the fluid composite, and one could pick some of these tests to address some of these functions listed here. Now, there are, of course, as I said, various advantages of these tests. There is good test retest reliability. There is convergent validity that has been demonstrated. The feasibility in older people has been demonstrated. There are different languages available, of course, especially English and Spanish for NIH Toolbox, but for the CAN tab, there are 15 languages that have been well examined. The association with biomarkers for validity of these tests has also been looked at. But there are many other tests that one could possibly look at for attention and information processing speed. For example, the symbol-digit modalities, for the digit symbol substitution. For executive function, one could look at the trail-making test, the Stroop. For memory, various kinds of list learning tasks are available. So really one has a lot of choice, but our suggestion is to use an optimal computerized battery. One has to address confounds, as I said, in terms of emotion, and as well as the other confounds in relation to the control group that you use. One could possibly look at some secondary measures of aging in addition to cognition, but of course, cognition has to be the primary measure of outcome that one is looking at. None of the secondary measures in itself will be sufficient as an outcome, but they could be supportive measures. For example, neuroimaging measures, one could look at brain wave or white matter volume, look whole brain volume, white matter lesions, various diffusivity measures, functional imaging measures, and network measures, and the various measures of brain aging brain age that have been looked at in relation to neuroimaging that have been applied in various aging studies, such as this example of using white matter microstructure, gray matter, activation in relation to working memory. One can look at various indices. This is just an example, just to show that there is significant overlap of older and younger people in relation to performance on these measures. And of course, the 1-year span of the study that we have currently is not usually sufficient to have good change, measurable change in many of these measures. And then, of course, there are molecular markers that have been developed, many of them for a disease such as tau and phosphorylated tau for Alzheimer's disease, but neurofilament light or GFAP, should say glial fibrillary acidic protein for astrocytic activity, markers of neuroinflammation, markers of blood-brain barrier integrity, epigenetic markers, especially epigenetic clocks, have been described, but none of these, again, in itself would be sufficient as a marker of brain aging, especially for the kind of design that is suggested for XPRIZE. So I end by saying that you choose robust cognitive measures appropriate for the population being studied, measure the domains of fluid intelligence most affected by normative cognitive aging, address the confounds, both in terms of the test in relation to the population, as well as the population itself in relation to the control group that you select, and can include secondary measures as supportive factors. Thank you very much for your attention.